So Marianne has kindly agreed to give a quick few slides on her experience. Taunton came in, certainly not one of the first to come in, but I was glad that Marianne was able to give these talk, because clearly Marianne and her team have done exceptionally well during the last 9 months, when so many of us have really, really struggled. Now, COVID may not have been quite as evident and around in the southwest as perhaps other places, but nevertheless, it's a fantastic effort what you've achieved, Marianne, and I look forward to hearing your thoughts.
Okay, well, yes, well, thanks for asking me to speak. You gave me two remits. One was, as you've mentioned, the recruitment through COVID, but also you've highlighted that we're one of the centres that recruits the sort of highest proportion of acute biliary patients, and you wanted me to speak on that as well. So in terms of COVID, as you've mentioned, we have obviously had lower numbers in the southwest, which has obviously helped our ability to continue with potential recruitment and operating lists at present. We were originally reasonably hard hit in terms of our operating capacity going down because of logistics in the hospital, and actually we've only got 6 ITU beds, so quite a lot of our theatre space had to be used as ITU. So we were slower than some trusts to get going with elective operating, and we have also had the disadvantage that our main research nurse, who would normally help with Sunflower Study, has been put on COVID projects until about the last week or two. So COVID has reasonably affected what we've done here. In terms of the acute patient side, the way we work at Musgrove is we've recently set up an ESAC service, so an emergency surgery ambulatory care service, and actually about a third of my time is dedicated to that. So that's part of the reason why there's more acute patients, because that's where I am to identify patients. We also do a fair amount of operating on our emergency list, so patients that come in acutely, we will operate on acutely. And we've worked a lot with the MR department to enable us to be able to recruit those urgent patients. So overall, my message here is, to get this to work, you basically need to engage people, and there's multiple groups of people that you need to look at: the consultants who the patients belong to, trainees who are a great asset, especially at the moment where research nurses aren't as accessible, research nurses and other nurses in the hospital, and I think one of the most important for the acute patients is engaging radiology. So if you can go into the next slide, please. So as a consultant, I am actually probably recruiting about 50% of the cases that are coming through at the moment. It's part of my standard consent of patients if they're eligible for the study. When I see them in clinic or I see them in the wards, I run through the risks and complications, and when I get to the potential risk of bile duct stones, I will always say, and we're doing a study to look at this, and then go through the process with them. I find the majority of patients are receptive if it's sort of given as part of the general consent process. And I would say the only patients that really don't agree to consent are patients who are going to go home and have to potentially come back for an MRI and then have either childcare or transport issues to do that. I would say most other people seem to be willing to participate. It's obviously a good idea to engage others. We had a lot of problems at Musgrove initially because actually we use lap ultrasound fairly regularly in our patients, and therefore a lot of consultants felt that this was the best treatment arm, which obviously is not available if you use the Sunflower Study. But having had a lot of face-to-face conversations with any of the consultants that had issues, actually everybody is now on board and engaged with participating in the study, or at least not being obstructive to their patients being included in the study. And I found that being accessible to any of the trainees or anyone who may identify potential patients is obviously a good way that people know that they can contact you at any time to discuss a potential patient, which is going to help your accrual. Can you go into the next slide, please? And then looking at trainees, we have a lot of trainees here. I think probably over the last 2 years, we've had at least 20 trainees that have been on our delegation log here. basically every time we get a new cohort of registrars or SHOs, I always try and go to the induction meeting to invite them to participate in the study, and we normally then try and follow up on that, because obviously those who haven't got GCP need to obtain that before getting on the delegation log. We're on to our second associate PI now, which again helps engage with the trainees and give them more of a role in the study. The way we generally work it is that we've got a WhatsApp group, and if I know I've got a little bit of flexibility in time when I'm going to approach a patient, then I'll put on the WhatsApp group, I'm about to approach a patient, is anyone free? And then basically anyone who hasn't yet consented to the patient or doesn't feel comfortable will hopefully be free to come with me and go through the process with me. And we try and do that once or twice with each trainee, so that they get used to the process with support before they're expected to do it by themselves. So I think that process works well with engaging them. And the majority of the trainees who I've got on the delegation log have been involved in actually recruiting their own patients. Go on to the next slide. So nurses have been really invaluable. Our normal research nurse is very keen and enthusiastic, but unfortunately has not been able to dedicate our time to the study since COVID. And so virtually all of our recruits have been outside the research department. But what we have managed to do is we have 2 ambulatory care nurses. One of them has got GCP trained and will approach all the patients coming through the ambulatory care clinic when she's available. And our upper GI specialist nurse again has done the GCP training, so he's come and consented some of the patients on the ward. And that's really useful. The second ambulatory care nurse, who hasn't yet done her GCP, still is happy to identify patients and then contact people in the WhatsApp group to get someone else to come and consent them. And they have really been invaluable as well in us identifying patients. And then if we go on to the last slide. So radiology have been really, really important in terms of getting the acute patients. We spent, again, a long time at the beginning of setting up the study, going down, having meetings with the MRI department, working out the best pathway to get the patients done. We'll send them an email and let them know if there's urgent patients needing to be done. If we are wanting an acute patient to have a scan, or possibly going to randomise somebody to have a scan, and there's less than 48 hours to do it, we'll phone the department beforehand to confirm that they would have capacity. And again, they're very receptive to that. And certainly one of the things I found a big benefit is if, say, somebody comes in on the colorectal team, they automatically get booked for an MRCP, and then they get highlighted to me afterwards. It's obviously a big win to be able to then go to radiology and say, wait a sec, somebody booked an MRCP, we're cancelling this MRCP because of the sunflower trial, so they can see that actually they're not just getting more and more work, we're actually potentially taking work away from them. And I think, radiology are absolutely the key in terms of getting a very acute patients, because if you haven't got a good relationship and they're not going to scan the patients potentially for 4 weeks plus, then you're not going to be able to capture that acute cohort. Next slide, please. And so a lot of it focuses around our WhatsApp group, which I'm sure lots of sites have. We have about 20 people on ours at the moment. We've got the ESAC consultants on there. We've got, I think, about 7 registrars, 6 SHOs, 1 research nurse, 2 ambulatory care nurses, and 1 upper GI specialist nurse. And it means that even if someone's not in a position to consent that patient, if they identify someone, even though the SHOs on night shift might identify somebody for the morning, and then we can pick that up when somebody comes in. So that's really invaluable communication. And last slide, please. So yeah, general messages: engage people, talk to people, show people what they're meant to be doing, and hopefully people will follow. Thank you.
Thanks, Marianne. That's brilliant. All great points. It's all about communication, isn't it? And being involved and showing an example. Any questions for Marianne before we let her get back to her opera? Which one are you actually part of, Marianne? Is it the next one of these, or is it the?
Yeah, the next one. Yeah.
Yeah, brilliant. Yeah. So guys, Marianne's not staying with us for the rest of this meeting. So any questions for Marianne? I'm sure a lot of the points that she's raised will come up in the breakout sessions. Well, they should do, because they're all fantastic points. But any questions?
I've got a quick question. Marianne, that's brilliant, and I'm really impressed at how you've kept it going despite the research nurses being redeployed into other COVID research.
Yeah.
And what's particularly unique, I'd say, I haven't heard anyone manage to engage ward nurses and staff nurses or CNS nurses in this type of study. I've occasionally seen them involved in a few other cancer trials. What do their line managers and ward managers think about the kind of everyday nurses spending time doing research? How does that go down?
Well, I suppose, yeah, I wouldn't necessarily class them both as everyday nurses. I suppose because our ESAC community, in terms of the ESAC, there's 4 consultants who primarily do it and 2 nurses. So we kind of work quite closely as a team. And I think they, ESAC nurses, have, even though one of them hasn't yet done her GCP, they've really engaged with the study, and it's almost the first, you know, as soon as they think someone's for lap chole, they will say, is this somebody for sunflower? They just see it as part of the process, which is really nice. And in terms of our upper GI specialist nurse, because I mean, we're a benign centre, so their interest obviously is more in benign process. And I think, again, he's a really nice chap, very engaged, and, you know, again, wants to expand his role and see the interest, sees the interest in that. So it's obviously not necessarily for everybody, but we have found, again, it is, as you said, a resource that I haven't seen used elsewhere before, but they're all really engaged and sort of see it as a real positive part of their job, I think.
I think there's huge potential for future trials to engage more with the normal nursing community beyond the research, but that is another debate. But I think there's another important clinical practice changing piece of work which you seem to be leading the way on. So well done.